Well, we're out here in Ghent, New York. We just got a half a foot of snow at Marshall Health practice. My Marshall Health, most people who have seen this are probably sick of hearing about that, but you are here.
I trekked down from the Great North, which didn't get much snow, actually.
No, and we got like 5-6 inches.
Yeah, we got about 3.
Yeah, it wasn't bad.
Yeah.
But yeah, no. So
priority one urgent care in Guilderland.
We are heading into spring. Supposedly, we just got.
No, we're not heading in there. There's no way any of this is close to being heading into spring right now.
Well,
if you look out the window, it's not.
I know. No, it's March, so we could talk about some spring-like things and some March-esque things.
I think we're still seeing upper respiratory season. We're in the throes of this respiratory thing, right?
So that's interesting. What have you been seeing mostly?
The big hit from influenza A has tapered off for sure. Mm-hmm. That was December and early January. But there's been a little surge of influenza B, which always comes later than A. We always see that. So there's been a little bit of that. We've definitely seen a smattering of COVID-19 out there.
Yeah, I felt like, what was it, Dara? We had a couple of cases recently in that early February.
Yeah, and then we've also seen a handful of, RSV.
Oh,
we're testing really? RSV in the office, and, and we've seen some folks, and typically, it hits, very young children, babies pretty hard, mm-hmm. but also it tends to hit asthmatics, people with chronic lung disease pretty hard too.
So they have the RSV vaccine now. Are you familiar with that one?
Somewhat. Have not gotten it myself.
So they have the RSV vaccine, and people, we talk about it, at annual physicals and whatnot. People ask, should I get it? Should I get it? I tell people, if you are somebody who would feel more comfortable being vaccinated and you meet the criteria, then yeah, go ahead, get it. If you are somebody who really is apprehensive about vaccines, then it's probably one you could live without. It, internal medicine, primary care, RSV rarely hospitalizes adults. It doesn't really kill adults. It's not, not a high mortality. But it makes you pretty sick, and it'll last, 3 to 6 weeks.
The adults I've come across like that really have had underlying lung disease, structural lung disease.
So that's what I tell people is people who should consider the RSV vaccine, primarily elderly with lung disease, even high blood pressure, heart issues, diabetes. Because if you do get RSV, you need to go on steroids. Right. Steroids drive up your sugar, so there's those comorbidities and compounding factors. So not always directly lung disease, but additional
but the rest of them, the folks without that who get RSV, it's basically a big head cold. I mean, and that's what it is, and it's going to linger, like you said. It's going to be annoying. You're going to do all kinds of remedies. Probably going to end up on some form of antibiotic because you're going to call you many times for complaints that aren't getting better, and that's what you're going to end up reaching for. But the reality is, it's a viral syndrome. It's going to burn itself out when your body decides to fix it.
That's also why we do the we do rapids here. We do the flu A, flu B, and COVID, but we have the viral send out, the PCR, which I think there's like 12 or 16 viruses they check for. They check for RSV. Sometimes people are like, is this really necessary? I'm like, well, not really. Like, you're going to go on antibiotics, but if it comes back with an RSV or an enterovirus or rhinovirus, at least we know what we're dealing with. So when you're still sick in 10, 14 days, it's not go to the third antibiotic. It's like, listen, this is still gotta.
And that's a really good strategy that I endorse as well. We don't, I've inquired of our lab partners about sort of that multi-platform viral panel, and I can't get it, unfortunately, at least not in any kind of a timely turnaround fashion. But from the standpoint of knowing what you have and what it would be responsive to or not, that's very helpful.
Well, the other thing is, we saw a woman this morning who was just on vacation with her husband, their daughter, son-in-law, and their 2 grandkids. She came in, she's sick. She's, she'll be patient A of probably 3 or 4. So kind of like, hey, let's swab you, because then when everybody else gets sick, we know what we're dealing with already.
Yeah, absolutely. Yeah, and it's a lot of rhinovirus up there right now as well. So therapeutically, I guess the question is, so what do you offer these people other than Tito's, Tylenol, and Time?
I mean, for RSV, symptomatic wheezing, oral
never
steroids.
Mind RSV. Well, okay. You can give
so for viral upper respiratory illness, oral systemic steroids are sort of great, but the side effects are
seems like a pretty big grenade to lob at that.
Well, again, it depends on are the people huffing and puffing or they have a head cold.
Right. Well, let's say they have a head cold.
They have a head cold. It depends. Like, again, the woman this morning is asthmatic. She, she's coughing a lot, not really wheezing. She has a nebulizer at home. I said, you should be doing your nebulizer 3 to 4 times a day right now, because that's going to keep you off of the steroids and getting really systemically ill. Otherwise, the decongestants, you and I were talking about that a little while ago. So yeah, somebody with a head cold goes to the pharmacy to get a decongestant. Which one do they get?
So it depends.
There's literally a aisle of
there's
cold and flu.
Because people complain about these symptoms quite a bit, as we all do. I'm sure you get your annual seasonal cold. I know I do.
Yeah.
Now, is it allergy? Is it infection? Is it other irritant, other source of
So
irritant?
speaking of coming into March, as we alluded to, now you got your cold season, but you're also coming into allergy season.
Right.
Absolutely. So now do I get a decongestant? Do I get an allergy medicine? Do I get an allergy medicine with a decongestant?
And the question, in simple terms, when I talk to people, I say, are you more runny? Are you more stuffy? Or are you both? Mm-hmm. And some people say one or the other or both. And then I react accordingly. But in terms of how I want to approach this, it's kind of a function of the degree of their symptoms, but also who they are, what they got going on underlying. So, I do not endorse the use of systemic decongestants, oral decongestants, or systemically absorbed decongestants for example, men over the age of about 35 or 40. It tends to induce prostatism. Their prostate gets large, and that's...
When you say decongestants, which are you talking about?
Well, pseudoephedrine is probably the granddaddy.
So phenylephrine.
Great works great, but significant systemic effects potentially. Tachycardia, rapid heart rate, elevated blood pressure, dry mouth.
So this is your phenylephrine, Sudafed.
Urinary retention, right. Palpitations.
So again,
tremor.
So phenylephrine and Sudafed.
Right? Well, I don't use those brand names. I just say like Pseudoephedrine.
Okay.
Right.
But phenylephrine is the chemical.
Yeah, that's those are that category. They're all together, kind of lumped together.
And then we have then you go to the allergy section. They have loratadine D.
Well,
fexofenadine D.
So and the D, when they say D, means decongestant,
which is
pseudoephedrine, phenylephrine, one of those things.
Mm-hmm.
So one has to approach them with great caution, I think. Now, hey, if you're 20 years old and you have both kinds of symptoms and you're okay with, you're a healthy person,
mm-hmm.
you want to take one of them once a day in the morning, typically for a few days, I got no problem with that. I'll recommend that. But if you're 80 years old with underlying coronary disease, hypertension, etc., back in my days working in the ER, I would see these people come in with serious,
issues,
serious presentations. People who...
And it could have been a decongestant.
Oh, absolutely. Yeah, over-the-counter medicines and multi-symptom cold relievers, chock full of this kind of stuff. Multi-symptom cold relievers are convenient, but unless you know how to read the label and what's in them and what you're trying to target with what's in them, that's a real challenge.
And in an appropriate time frame, right? If you're not getting better in 2 to 3 days, it's probably time to seek treatment.
Right.
Or certainly if you're getting any worse.
Glyphenicin is uber prescribed, right?
And it's over the counter.
But not prescribed, but directed. When I went to medical school, I do remember doing some rotations when glyphenicin under various names was prescription. Now it's
you still can get a prescription glyphenicin. 100%.
Well, it's compounded with codeine for cough syrup, things like that.
It's compounded with everything.
Yeah.
Glyphenicin is a pretty safe one, would you say?
I just don't think it's very well. I can't say it's not effective because my problem is we have selection bias in our business. We see everyone who's a treatment failure. We mm-hmm. don't see anybody who's a treatment success because they don't come in.
Well,
they
and
feel
you also
better, right? But I see people come in and say, I took this and it didn't work.
But also my experience is, your pseudoephedrines and your decongestants work from, the neck up, and your guaifenesin typically works from the neck down.
Correct. And that's a great observation, Ryan. Good job. You did. Because, really guaifenesin is an expectorant, right? Mm-hmm. To help you get stuff up out of your lungs. If you don't have stuff in your lungs, it's not going to do anything for that. If your primary problem is you're coughing because of postnasal drip, you need to drop the drip to stop the cough. It's like a leaky faucet. You got to turn off the tap to stop the drip,
So I think if, for folks who are watching, I think the short answer is you think you're coming down with a head cold, a little runny, a little stuffy, you don't feel well. Talk to your PCP, maybe send a message through a portal, assuming you have a PCP who has a portal, and say, hey, I haven't been feeling well. These are my symptoms. Which one of this conglomeration of stuff can I take? As they have, you got your Tylenol, cold and flu, and then you have every single pharmacy and grocery store has their own brand,
Okay.
and some of them have
Lots of
pseudoephedrine in it. Some of them have
Phenicillin,
guaifenesin. Some of them dextromethorphan.
phenylephrine,
Some of them have 2 or 3 of these. Some of them
lots
have
of antihistamines, a lot of Benadryl, right? A lot
yeah.
of
Which
diphenhamic,
let's talk about Benadryl.
Right.
I mean, and then again, going back to Dara and I have talked about like sleep medicine, Tylenol PM. What is Tylenol PM?
It's Tylenol and Benadryl.
Right. So what's Tylenol? Tylenol Severe or acetaminophen Severe, cold and flu, and it's day and night. What's the difference between the day and the night? The nighttime has the Benadryl. Right.
The daytime has the pseudoephedrine.
Okay, and 7-year-old with an enlarged prostate should have
no pseudoephedrine.
Neither of those, really.
For sure, no pseudoephedrine.
Yeah. So again,
but I guess the question is, so what we kind of beat this up. What do we do? So I mean, for me, historically, going back, you mentioned steroid therapy. I love nasal steroid spray medicine.
Okay.
Now, why do I love that?
Well, it's not systemic.
It's not systemic. Exactly right. Now, it's not super potent either, like a systemic steroid.
It's pretty
effective. But if you're directly acting on the mucous membranes that are causing the problem in your sinuses, in your nose,
100%.
Then that's the target.
You have somebody, and it doesn't have to be an elderly person. You have somebody who's on long-term anticoagulation. It's a dry winter, lots of dry heat. Go on a nasal steroid for a few weeks. You're seeing them for.
Well, you got nosebleed.
Nosebleed.
You have to taper or not taper. You have to consider all like that. It's patient factors. People think this is easy because we make it look easy, but you got to think about all of these possibilities.
AI makes it look easy.
Right. Well, that's true.
But when you put your sinus symptoms into AI,
right.
It probably doesn't ask, are you on long-term anticoagulation?
Right.
Do you live in the Northeast? Have you been indoors with the heat
for
have 5 months?
Do you have forced hot air heating, which we have in this room right now? It's actually kind of killing me. But in that case, well, maybe I'll say we'll cut the dose in half, or we'll spread the dose out twice a day instead of once a day. And we'll make sure that you're hydrating up properly and with a vaporizer and things like that.
The other thing we haven't mentioned, which is like my favorite, is the nasal irrigation. To me,
I knew you'd love that one.
You want
to demonstrate?
I'm good.
I've
done it plenty, but no, I mean, the neti pot. I don't really love the neti pot. It's kind of like you got to sit upside down.
Special kind of guy who likes the neti pot.
They have these squeeze bottles, which I tell people, I'm like, what do you do when you're sick in the summer? You jump in the ocean, you feel great.
Yep.
What is the nasal irrigation? It's basically salt water going through your sinuses.
That's what I tell people.
It's phenomenal.
If you can find it, white sand, blue water, stick your head in the blue water and blow bubbles out your nose.
Yeah,
that's kind of it.
For the babies.
The nose Frida, yeah. We were in urgent care years ago. Remember, I contacted the rep and we got them, and that's nasty because that's like a suction.
It's a sucker.
And,
but that actually, Dara, great point. Dara behind the camera, great point in terms of the source of the problem. You both are actually hitting the nail on the head because the whole thing is what? It's snot, which effectively is like pus, and pus effectively is, if you're thinking about a classic sinus infection, it's trapped pus in your sinuses. We can give all the antibiotics you want. If you have trapped pus, you can't fix it. You can't fix pus, as we say, with bug juice or antibiotics. You got to get the pus out and then give the antibiotics a chance to do their thing, if in fact that's the situation. So with the babies, we always say the key to good living with little kids, because the kids can't blow their nose. Yeah. You got to get the snot out of little kids' nose. That prevents so many complications like secondary ear infections, that kind of thing.
So let's just go backwards. So a few days of cold symptoms, no fever, head congestion, maybe a scratchy throat. What do I do?
What I do,
I'm a healthy 30-year-old and I don't take any other medications.
Well, if you came to see me in my office, you'd probably get a viral swab, because what's going around right now. Because people like to know the diagnosis if we can give them the diagnosis. That's number one. Number two, we're going to say, well, you probably have a cold. You could do nothing. What I have to say is, well, what would mom do? I kind of alluded to that. Tea-toast, Tylenol all the time. But really, rest, fluids, salt water gargles, maybe some nasal irrigation if I can convince a 30-year-old guy to do that, which I probably can't. But, and I'll say I would try the nasal steroid spray for a week or two. It doesn't work episodically. You can't use it for one day and expect it to work. It won't work that way. Steroids don't work that way. But I think, and depending on if you're really feeling more runny versus stuffy and you're a young, healthy person, you want to go on a little bit of one of the oral agents that we talked about. Okay, we could give that a shot. And if things worsen, obviously we want you to come back or talk to your PCP, and educate you as to what worsening really means. Worsening isn't I didn't get better tomorrow.
Yeah, worsening is like I'm not getting
worsening is
worse.
it's been a whole week. I've done everything you told me, and now I have a throbbing facial headache. My upper teeth hurt. I'm blowing out large volumes of bad looking snots. I'm having chills. Okay, now we're thinking about a secondary process like a sinusitis, right? People don't normally wake up with sinusitis; they develop it secondary to an upper respiratory infection.
And I tell people all the time, antibiotics are great for causing other problems, yeast infections, antibiotic resistance,
allergic reactions.
Get into some of the other medications,
diarrhea,
allergic reactions, but also interactions with medications. Quinolones and statins. Let's go.
Or anticoagulants.
Yeah. All right, so that's a healthy person. You get into your, let's say we have a 35-year-old pregnant woman. That's always a fun.
How pregnant?
Second trimester,
of course,
because they can't take anything.
You wimp.
Yeah.
Take one.
No, I mean sinus again, viral upper respiratory symptoms.
Well, first of all,
pregnant
second trimester. Question number one: have you talked to your OB?
That's
that's my go-to. I'm not your OB.
That's called deference.
That's called deference. Well, it is. Now you may be working in a rural area. Where maybe access to those kinds of services aren't so easy to come
and
by.
again, the nasal steroids, because they're not systemic,
absorbed.
they are typically endorsed by obstetricians.
Right.
But again, you got to also be careful with the difference between a nasal steroid and nasal antihistamine.
Oh,
if they're not the same and they're next to each other on the shelf.
And you have to tell the person which one to get.
Yeah.
Or
how often to use it,
say,
and
I have
duration.
A spray, say, show me the spray.
Yep.
Or give you the name of the spray.
You start using Afrin. After 3 days, you're just causing more problems.
Well, Afrin's a decongestant that has an interesting side effect profile, I would say, but I think more about the spray antihistamines. Mm-hmm. So the mazolestines, those things, which I'm probably mispronouncing. I apologize.
Zalestine. But again, when you're when you're a layperson, you go, you're an engineer.
Right.
Take my brother for example. I mean, he goes to the store. He's like, all right, cool, I'll grab this one. He doesn't realize there's a difference between fluticasone and his Zalestine.
Right. And there's a huge difference. And again, going back to the good old days, I can recall having people come in who use products like that, meaning the antihistamines, where they were so sedated, older folks with comorbidities who were so sedated by it, actually had to put them on ventilators temporarily because they were out, and that was the root cause. So really, a lot of these medicines that are sold over the counter, it's great, it's convenient, but unless you know what you're looking at and what you're trying to treat and target, that's why I don't love multi-symptom co-relievers. They pack a lot of different things into a small space. Most of those different things aren't going to be helpful for your particular symptom. What is in there that's helpful, there's not really enough of. So the rest of it just goes towards creating side effect possibilities.
Yeah,
Does that make sense?
Yeah, it does, and it's confusing. It's even confusing for me. I was at this, my kids were sick last week. I think flu B and COVID.
You didn't bring them in? Really? Thanks.
I need but I went to the I went to the pharmacy and I was trying to get like a daytime decongestant, and it was all my daughter was all up here, so I was trying to get her Tylenol for comfort. She had some low-grade fevers. I was trying to get her something with a pseudoephedrine in it for the congestion, and she had a cough, so I was trying to get something with dextromethorphan, but she didn't need to guanfacine, which also doesn't come in like a full combo, and it was unnecessary. I wound up getting a couple of different combinations.
Yeah, still
I basically make
your own multi-symptom.
I make our own, but I also know what they all are.
Right.
Yes, and the doses.
And you want to get the right dose. So in terms of you mentioned the oxymetolazine, Afrin.
Mm-hmm.
We do in our practice probably lean on that fairly heavily. I'm not going to lie.
For short periods of time.
For a short period of time. Well, and the point is, there's maybe a misnomer about addiction. There's not an addiction in terms of a physiologic addiction.
It makes you feel better.
It makes you feel better, but it loses effectiveness rapidly. So you tend to use more and more and more and more frequently to try to compensate for that, which is perceived in some people's minds as being addictive. And I tell people, if you've used this before and had a problem with it, don't use it again. It's not worth it. There's not that much of a benefit. But if you're really stuffed up to the point where I can't get that steroid spray to get up there and penetrate, let me have you open up, and I can't lean on oral.
Really good is nasal irrigation and then your nasal steroid afterwards.
If the irrigation will penetrate, but some people are really plugged. So I'm like, listen, do a couple sprays of the decongestant spray, open up, wait a half an hour, blow out whatever is accumulated, then hit your steroid spray up. and it might have a chance of penetrating.
All right, so we got your healthy people, unmedicated, pregnant. Now we get into your 70-year-old
unhealthy people.
70-year-old who's.
Why do you look at me like that?
Uh,
Not 70.
we just got off the phone with my parents. They're in that
Your
generation.
parents?
Yeah.
My generation, your parents, really?
A little older, but
No,
so okay, so mom and dad have drove down to Florida for the.
If I see your dad
winter.
coming in, first of all, I'm calling 911. It's not even. Sorry, Pat, but that's how it is. Okay.
So so now you got your elderly folks, multiple medications.
Yep.
No fever, been sick with a head cold for
Right.
3 days.
Right. I mean, those folks are allowed to have the same viral upper respiratory syndromes that you and I can have. So you got to do an assessment, got to take a history. If you feel like that there is a chance for significant decompensation or there's a risk here that you really want to protect against, then you got to make a call. But I would say I will use less of the decongestant antihistamine medicines in those people because.
That's probably a population
right.
where systemic oral steroids and antibiotic are probably used more liberally
Right.
and sort of prematurely rather than let's wait for somebody to have pneumonia.
I'm probably not using systemic oral steroids necessarily unless there's a real good indication for that. And have I used it for people with sinusitis, etc.? Yeah, I have. And usually it's a very low dose because even at a low dose, that's a lot compared to what you're getting with the spray, the nasal spray, and it's still systemic. So, but again, it's 5 days, 7 days, probably not going to precipitate significant decompensation or side effects, probably. But yeah, am I more liberal with antibiotic use in that population? Not going to lie, yes, I am.
Yeah, no,
and I think you have to be because.
But it's more preventative. At that point, it's also more preventative.
If
than
this is
treatment.
someone who's a patient of yours, for example, okay, now we have a care plan that can translate. Do I have to go put this person on some medications like that? Not necessarily.
No,
they're going to call you up and say, or text you and say, "Hey, get Mrs. Jones in tomorrow for 2 days for a recheck. Here's what I got," and you'll be like, "Okay, that's fine." Versus someone I don't know who they're going to see.
Or maybe they don't have PCP,
or they only see cardiology because they lost their primary care, went over to concierge practice, and they got thrown out. So so if I don't know where they're going to end up, I'll probably be a little bit more protective or aggressive or proactive in terms of that treatment scope because. Is it defensive medicine?
Yeah, you sort of but you're also sort of releasing them to the wild, right? Like, exactly. Hey, good luck. I hope you feel better.
You tell them to come back, but will they? Although a lot of these folks, they went to the other urgent care down the street. They thought it was the same place. They didn't realize. Yeah. We get that sometimes where we're at. So it's a challenge. I would say you have less options. At the same time, I do want to be more aggressive about testing them probably because if they do have a viral syndrome that I can actually treat specifically, aka COVID or influenza, I will.
Yep. Or I have some people who, guess what? Your viral panel, which is pretty comprehensive, came back negative. You're not getting better. Now you're going on antibiotics.
That could be too. Yeah.
So we talked about the head cold, runny nose, all that stuff. Let's just cover allergy symptoms. So how you differentiate.
All, can people have allergies in the winter?
Yeah. Dust allergies are terrible.
Number one,
because you're inside.
What happens? The heat comes on, the dust mites come off the radiators, and you're sick. People don't understand that sometimes. Or you're trapped inside, more of the animal danders contained, that kind of thing. So all the time. Yeah.
But as we get into more of our environmental allergens, so differentiating between cold and allergies, symptoms go.
Itchy, watery eyes,
watery eyes,
sneezing,
scratchy throat versus painful throat,
fever.
No fever and allergies.
No, right.
Afebrile.
Bad looking snot versus clear snot.
So clear snot being
those are all kind of soft. There's really no one differentiator, but also
what about red eyes? Both eyes are red.
First things first, we get a COVID swab for that.
Really?
Yeah. Acute conjunctivitis without otherness or upper respiratory symptoms associated, probably gonna get a COVID swab. Well, won't be positive.
I was getting at the red eye because allergies are usually bilateral versus bacterial conjunctivitis is unilateral.
Okay, well, there's also whatever. Okay, he's being very, very cerebral right now. This is good. You've come a long way. You learned. Don't put steroid drops in your eyes, by the way.
For lots of reasons.
Unless it's directed. But no, so in terms of the allergy profile, also the seasonality to it. If someone says, I get a sinus infection every April, and it's characterized by itchy, watery eyes, sneezing, and clear snot that won't give up, I'm thinking maybe it's not a sinus infection.
Correct.
And maybe I'm going to treat this person with 4 weeks of nasal steroid spray, with a week of oral antihistamines to start with to jump it off, and refer them to allergy immunology for testing and further evaluation
if they want, or they can just
want.
take their antihistamine.
Well, but sometimes they want to get a more definitive evaluation and and treatment course where they can maybe be theoretically cured of the problem. So they don't have to go back every year to bug somebody for antibiotics that they probably don't need.
Yeah.
I mean, that's the thing. So I mean, I think there's a lot to that. I'm an allergy sufferer. I've been through my life through 3 rounds of immunotherapy, allergy shots. The third time was way back in the 1990s, probably around 1992 or so, or 93, and I was really sick. And the guys I ended up going to in Albany did a great job getting me cleaned up, both acutely and then long term. And now, I mean, I don't see them anymore. I don't need to. I do a nasal steroid spray, really just like April through November. And that suppresses me. And then in my peak times, which would be around late May and then around Labor Day for ragweed, I'll do an oral antihistamine for about 2 weeks on top of the nasal steroid. And that does it for me. But, we've had 3 cats running around our household now. And it doesn't bother me, which is great. So, and there's been a lot, that's going back now 30 odd years, right?
Yeah.
And there's been
When
a
you
lot
say
of
cat in your house, all I think about is the one that I think threw up on my jacket.
Yeah, that was one of them.
Yeah.
I think they're dead now, but anyway. So I mean, I think there's been a lot of improvements in the 30 years too, in terms of allergy therapy and technology now. So it's even better. So I always recommend people do that.
What is it? Well, the immunotherapy,
the drops, all that kind of stuff.
Yeah, I'm trying to think of the asthma stuff, the injections. Not IgG.
I don't know. It's high tech. I'm allergic to it.
No, there's really good immunotherapy, and I'm trying to think of I have a couple of patients who go for it, and the name is escaping me, but it's highly effective, particularly in eosinophilic asthma and eosinophilic rhinitis. It's like a game changer, truly a game changer for people who've been suffering their whole life.
Yeah. So that's why I'm saying, you can do these oral meds every day and whatnot, but there is really effective methods out there, and and I'm a big proponent of that. I think hey, why not cure this thing if we can? I mean, that's what we're in business for, right?
100%.
I mean, anybody can do a Band-Aid approach. God knows we do enough of that as it is, don't we?
Yeah.
So
cool.
That's what I got. What do you think?
I think that's good. I think trying to keep you under an hour is a challenge. So I think I think we sort of coming into spring, a little bit of cold, going into allergy season. And before we started recording, we started talking about tick bites, which we'll
maybe a future conversation.
Focus up on more. I always feel like for me, April and May.
You're gonna get bitten in March.
No, 100%.
I mean, 1 week of warm weather in the mid-40s.
Last
come
May,
alive.
they were awful last year. We'll get there. We'll get there. So cool. Well, enjoy the next few weeks. Try to get some fresh air. We're getting little glimmers here and there.
Think white sand and blue water, my friends.
I still think
everything.
March is just an extension of winter, and it's like spring. It's like it is not spring.
Talk to me on May 1st.
It is windy. It is windy, rainy, snowy, nasty, muddy
through April.
So
syrup. Although the maple syrup season is upon us, right?
It's getting there.
Yeah, this will be showing up probably in the next week, which is a good thing. So
cool.
All right.
Well, stay well and stay out of urgent care.
If you have to go to urgent care, go to ours.